look, this is a big deal. This hearing from Todd is like going to be an important talk, a memorable talk. There's no question about it. I first met Todd. Actually, I got a call from your former chair, our beloved Karen Maraska, who I saw the other day at the women's thing.
She's still around.
Gave her a big kiss. One of the most amazing people I've ever met, I mean, is Karen, who, you know, served as our only woman chair of neurosurgery in the United States, doing it all from a wheelchair, motorized wheelchair. The mentor of none other than Sanjay Gupta, who was trained by her. Karen called me on the phone and said, there's somebody that you have to meet and support. You know, this is an order, basically. And I said, well, tell me about it. And we have this remarkable young man named Todd Hollon, who is going on to the tenure track as an assistant professor of neurosurgery. And he does this new thing that I've heard you talk about called artificial intelligence. Again, this was when artificial intelligence was kind of a dream, okay? It was before the LLMs, ChatGPT and all this.
This is before TensorFlow.
Before TensorFlow.
PyTorch, before any of that.
So he got in early. And he's got something to say. And, you know, we won't hold it against him that he's a Buckeye, right? Why would we do that?
It's just a little blemish.
He just, you know, he got his MD over there. He was a Michigan guy, went down south, got his MD and came right back home, did his residency here. And, you know, one of the fun things, and I don't see where's Renly at, you know.
He's going to highlight heavily in this talk.
Couple of our students, Renly is one of them, you know, Chang, you know, are over there in his lab with some of you guys from computer science. Welcome. What you're going to see is a remarkable story that is going to change lives. You know, to be able to actually use imaging in very creative ways and guide surgery while it happens and transform medical practice beyond neurosurgery to other forms of cancers, where you need a quick answer from digital pathology, but you can't wait for them. So why not do it a different way? And so Todd's going to teach us how to do it. His title of this talk is Multimodal AI for Neuroimaging. And glad you're here, Josh. I think you're going to love this one. And thank you so much for coming. And Scott will be joining us as a secondary faculty member in DCMB here in the next month or so. This is his job talk.
You got it.
Be hard on him.
Thanks so much. Thank you all for the invitation. Thank you for coming. It's starting to snow out, getting colder, and then all of the craziness at the NIH, a lot of hesitation within science, but I think, you know, trying to stick to what we do well, which is innovation, and certainly trying to have collaborations amongst colleagues has been a huge highlight of my career. I think that being a neurosurgeon and being within the neurosurgery department, it's certainly a huge part of my life, but I really enjoy most is collaborating with bioinformatics, with computer science and engineering, biomedical engineering, because I think that's really where my heart lies. It really lies on the research side of these kinds of things. So I've had the opportunity to sort of get in front of this big AI wave and try to figure out how we can use this to better treat patients. And obviously focusing on neurological patients because that's my clinical specialty. But a lot of what we talk about here today applies to any patients. Anybody who comes to the doors at Michigan Medicine, their lives are going to be touched by AI in some way. And what's so wonderful about this is we really are at the point in time where we're defining how AI is going to be integrated into clinical care. How is this really going to roll out in the next 50 years? Because it's coming. We all know it's coming. It's not controversial anymore. The question is, how do we influence that? How do we make sure that it's done in the best way, the way that we think it's going to optimize patient care, how it's going to help physicians do their job, how it's going to help us better diagnose and treat patients. So that's really what it's about. And this talk is just a small piece of that and what we've tried to contribute to this overall mission. So there we go. I've got to say a huge thanks to DCMB. Because when you come into a clinical department as a professor, you open a lab, nobody's coming through your door. There's no one there, right? So maybe you get a tech if you're lucky. But what I knew very early on with discussions I had with Brian was that I wanted to be involved with DCMB, not only because it's a fantastic staff. Matt, I've known for a very long time, since the very beginning, but because the students that I had interacted with were absolutely phenomenal. Chang was the first one for sure, and it was when he was still a master's student, and it just keeps getting better from there. So Renly is someone who now is just absolutely outstanding. He's really crushing it. And then Akil is a new MSTP student who's also in DCMB. And just, I couldn't be more impressed with these individuals. The best part of my day, these guys will tell you, the best part of my day is coming into lab and talking to them about the last idea I had last night at 11:30 at night, right? I did that today to Akil. So it really is a huge highlight, and it's all thanks to DCMB. So why medical AI should be multimodal? Usually my talks are very centered on intraoperative imaging and computer vision and how do we guide intraoperative surgical decision making. And we will include some of those things, but I'm feeling more and more strongly about this multimodal approach to medical AI specifically. And the reason I believe that is because patient comes in and has some illness, let's say has a seizure or has an intractable headache, has some left-sided weakness, whatever it may be, comes into the emergency department and we start asking that patient questions, right? We start collecting a history, and then we do a physical exam, and then we may obtain some lab values, and then we may get some imaging. The way to understand that is we're basically triangulating a view of this patient that's informed by different modes of collecting information. That's really what it's about. We need a radiographic representation. We need a natural language description. We need laboratory values. All of those are filling in what we hope to be a complete description of that patient to be able to inform what's actually happening, getting a diagnosis, and then ultimately getting a treatment for that patient. So that's why any single view, you imagine you come to the doctor and they say, we're not going to ask you any questions. We're not going to do an exam, but we're just going to draw a couple lab values. And that's it. That's all you get. That's the only view that you have as the physician to be able to determine what's the optimal treatment for that patient. That sounds absurd, right? That doesn't make any sense. But it's really up to what has been previously, up till this point in history, up to the physician to integrate all of this information about the patient to be able to decide what the right diagnosis is or what the right treatment is. We now have systems that are able to accommodate multimodal information to be able to decide what is best for that patient. And I think if we're limited to one mode, let's say it's just NLP or it's just computer vision, I only do time series stuff. That's going to be a problem when we think about how this is really going to look in the future, how medical AI is really going to look moving forward. So ultimately, what we need to do is build up, a complete patient representation. And this includes a lot of things. It's certainly not limited to any one. And again, we see these things every day that we're trained as physicians to take a family history and symptoms and performance status and all these sorts of things. And all of this is going to be really critical to medical AI. And then ultimately, we would need to do something with that information, right? And it's not one thing either. That's the other layer of complexity. It's not like we just want to predict survival or just predict a treatment, what the optimal treatment is. There's a lot of different things. Clinical trial enrollment. That's one thing that I think is absolutely essential now. It's absolutely prescient because we know we haven't done as good as we should do enrolling patients in clinical trials. Why? It's because it's very hard. It's very hard to know, if you're a doctor, what clinical trials are available for this patient, right? You have to know the diagnosis, you have to know which ones are open, which ones they're eligible for. You have to understand all the inclusion, exclusion criteria for all the different trials that may be going on at any point in the world. That is way too much for any single clinician to hold in their head, right? So there's lots of ways in which both the input needs to be multimodal and it needs to be a multitask output. So this is just an example of sort of a vision I have in my head about what a medical AI is likely to look like in the future. And for us, this is about neuroimaging because I do neurosurgery and work in the neurological diseases, and we've really focused on two things in the lab. So intraoperative imaging is really important to me, just because as a brain tumor surgeon, that's what I spend a lot of my clinical hours doing. And I can tell you, we do not do a good enough job as brain tumor surgeons. We really don't do a good enough job removing tumors from patients. And that's a huge problem. I don't think it is advertised well because it doesn't make us look very good when we say that we're leaving pieces of tumor in patients' head. We haven't done as good of a job as we should do. And it's an ongoing problem. We've been trying to innovate as a field, but I think we've been quite limited. And also the progress has been extremely slow over the last 20 years or so. So I feel very strongly about that. And then a newer research program and lab has been focusing on neuroimaging, classical neuroimaging, so things like MRI and CT. And the reason why I feel so strongly about that is because we know scale is important now. It is not controversial that if you have more data and bigger models, you will get better performance. There's very clear, both empirical and theoretical results about what you can achieve learning at scale. So this is something where we've been working with the hospital system to acquire health system scale data sets, both MRIs and CTs. Basically, it constitutes downloading all of the MRIs and CTs that have ever been done here at Michigan Medicine. And we have some preliminary data, which I'm going to show, which is really emphasizing the importance of training these models at large scale and trying to distill all of the information contained within these health systems to be able to get better diagnoses, treatment recommendations, prognosis, all this sort of thing. This is equivalent to internet scale training. We're all familiar with that now. We've all worked with GPT. That is basically a distillation over human text and images, depending on which model you're working with. But it's basically taking all the information that we can encode and digitize and have access to, and then using that to train a model. There's an equivalence with that in medical AI. We need to do it over health systems. We need to do it over electronic medical records. There are some regulatory issues that we need to overcome, but that's for us. That's for humanity to solve. That is not a limiting step. We need to fix that, right? So that's one thing I feel very strongly about. All right, so AI is sometimes scary, right? Terminator 2, HAL 9000, that kind of stuff. Okay, so we know extremely well reproducibly from the psychology literature that human performance, you have your training, you have your apprenticeship, whatever it may be, you peak usually about 4 or 5 years out. This doesn't matter if you are a surgeon, if you are a cardiologist, if you're Roger Federer, if you're Messi, it doesn't matter. You will see this curve, you will peak. There's a little bit of variability in how long you peak and which exact field that you're in, but it doesn't matter if you're Magnus Carlsen or whoever, you will start to decline. We're all mortal, right? It's just part of the world we live in. So we have to sort of understand that we need help as individuals to often do our job as well as we can, to do the things that we love to do, right? Often we need some help doing those things. And also, you'll notice that there is a peak here. There is a peak level of performance that we can all achieve for any given discrete task. And the question is whether that peak is optimal given any sort of closed system, right? And we know that it's not optimal for chess, right? We know that we are not optimal chess players, right? And that's where we start to question, are we optimal diagnosticians? Am I the optimal surgeon? I can tell you that one for sure, no. That's for sure, no. So we have to start thinking about what would be an optimal performance in any given world if we're not restricted by biological intelligence. I think that's where people start to get a little bit worried, but I actually think we need to embrace it because ultimately you do not want a faulty surgeon operating on you. No one does, right? It's not about the surgeon, it's about the patient. So you really have to think about it from a broader perspective and think about how you can actually push this peak higher and potentially push it further down the road. And like I mentioned before, this is not surprising in chess, right? Deep Blue beat Garry Kasparov a long time ago. The world didn't collapse, nothing happened, but we realized that chess engines always beat humans. So we know that we are not optimal agents for playing chess. What has been a little bit worrisome for people of late is that this is true for most disciplines we see across the human condition. So we learned it for Go. We have now learned it. We have level 1 evidence that AI is better at humans in diagnosing patients in a primary care setting. It is not controversial anymore. As long as you give an agent, a learning agent, sufficient data, and you give it a discrete enough task to be able to solve, it will beat us. Again, this is in no way reason to panic. This is a way for us to understand how this is going to help us in the future, right? This paper here, dermatologist level classification scheme, that changed my life. That was the paper when I decided I was going to dedicate my life to this. So that one is a great one. So diagnosing a melanoma, better if you have a computer vision system than with humans, for sure. Not controversial. This is 2017. So this is where we really need to embrace this as being part of the 21st century. And again, this is not a time to panic, right? We've got to talk about this and talk about how do we improve the human condition using AI, right? It's not about existential crisis, certainly not yet, because we're not even close, and we do know that humanity is going to benefit from these things. Okay. All right, I'll come down from the soapbox. Now we'll get back to some science here. So how will AI improve neurological care in the 21st century? So we picked MRI as a good use case, specifically for neurological diseases, because it is the imaging modality of choice. So a patient comes in with a new brain tumor, epilepsy, multiple sclerosis, pick your neurologic disease, most likely they're going to get an MRI. And that's what we use not only to diagnose, but to track the progression. It's ubiquitous. We have a paired MRI with a report from an expert neuroradiologist, which is great. And then we really have over 20 years of archive data. You remember the old light boxes you used to see? Now, we can't use those very well, but now, basically, starting around 2004, we started digitizing all of those scans. So now we have a digital PACS system where we can use that as data for training. So this is great. This is also, again, the problem with the way that we approach medical data, right? This is dead data. This is sitting in our Sectra warehouse doing nothing for anyone. It's just an archive. We need to get way beyond this, right? Electronic medical records cannot just be archives. They cannot just be descriptive. They have to be active. They have to be proactive. They have to be prescriptive. So this is where AI, I think, again, really can benefit, is that we can now use this to learn. We can improve the way that we roll out medical care by using this. Because right now it's just sitting dead. It's just sitting stored somewhere in cold storage, right? So how do we learn from all the MRIs that have ever been done since the beginning of time? Okay, so you may have seen this avocado chair, yeah? Anybody know the avocado chair, DALI? Okay, so avocado chair, people have probably worked with these, but they may not know how DALI, the original DALI, but also the subsequent DALI 3, were trained. And the way that you really do it is that you take an image from the internet, you web scrape the internet, and you get all of the images on the internet, and usually there's some associated caption with that image. And what we found out is that you can, at internet scale, as long as you have a caption, a good enough language model, which now we do, and also we can train an image encoder using this. Basically, the goal is to align the image representation coming out of the image encoder with the text encoder, LLM, let's say, and you want to align these two. Now, what's good about this is that the descriptions can be quite rich, and you can get more than just image classification or image recognition, like ImageNet. You can actually have some amount of understanding about what's going on in the image, and also you do not need to annotate them because the captions are matched to the images, usually in the HTML file or wherever you're getting these images. So it's a great way to scale to the internet size of doing something without needing people saying, is this a golden retriever or a Shih Tzu or whatever it may be. So this is what OpenAI did and really scaled it up to the very large. And they showed that this is a big step in computer vision. So that's exactly the paradigm that we had. This is called clip training or contrastive language image pairs. But you can imagine MRIs work beautifully with this because we have a dedicated radiology report specifically for that MRI read by an expert, someone who has gone through fellowship training to interpret that MRI at very high density, right? So we downloaded all the MRIs that had been done here at Michigan from our PACS server, which was a big effort, but we were able to do it. The radiology department was fantastic. And we were really able to show that we have representation not only across the entire state of Michigan, but also across the United States. So we were able to show that the residents for all of these patients really span the full gamut across different population types. So this was excellent. So developing this data set was a really important part of this kind of research. And then we need to figure out how do we build a computer vision system to handle these MRIs. For anybody who hasn't worked with this data type, it's not like a 2D image or a 2D RGB image, for example. What it is it's actually a set of volumetric images. So you image the head and you image it with a specific setting, sometimes called T1 weighted. Then you do it again, you do it T2 weighted, then you do it with flare, then you do it with contrast. So you end up with these 10 different volumes that all give you different radiologic information. And the radiologists often read them, sort of comparing the two. One may be more important than the other. It gives you context to understand this thing. But at some point, you need to distill all the information across all of these volumetric 3D images. And then you need to distill it down into a final diagnosis. You need to have a final output representation from that. So we used a hierarchical structure where we basically have, we split the image into smaller tokens. That's not new. Volume tokens or image tokens are similar to language tokens and LLMs. And then we process the series. That's the individual input. So again, this is all the same patient, but you have a bunch of different series for that patient. And then we integrate the information at the series level using the study transformer. And then from that, you get a single representation here, which is this black token. Okay, now you got the black token. What are you going to do with it, right? You got to do something. So this is where a fantastic student of mine, Yue, he really took this on. And we were trying to think, how do we do optimal clip training for MRI reports? And one of the things that we know is that the better the quality of the report, the better the visual representation learning, the better the vision model is going to be that can ultimately do diagnosis. So we wanted to standardize these reports and make them as informative as possible. And we used an LLM to actually distill, more or less kind of summarize the most diagnostic aspects of the report. These are very long, semi-meandering reports. There's no standardized way to get them to sort of, read these MRIs. But we figured out a way to completely standardize and summarize the reports. And then you can train a neuroradiology model to then give you a text representation of that report. And then it's standard clip training from there. Basically, what you're trying to do is you're trying to minimize the cosine similarity between the visual representation and the output from the language model. And again, you can do this over the whole data set, and we didn't need to really annotate anything. It was just the summarizations, but we got that for free now because the LLMs are so good. So we were able to do this with 220,000 MRIs. And this really hadn't been done before, mainly because of the complexity of the MRIs. It's quite daunting. If you're a computer vision researcher, it's scary to think about these multimodal, massive tensors that you have to deal with to try to get a visual representation out. And also understanding the reports requires some amount of nuance in terms of understanding neuroradiology. So, all right, we trained this big model, took us 50 days, big, large scale training, but now you have to do something with it. And the thing that I really want to emphasize for doing medical AI is you do have to go beyond a lot of times what you'll see in an ML class, which is just like a train validation test split, and then you'll get a result out, or even cross validation. I tend to think that that's usually insufficient for medical AI. You need to be more rigorous. You need a sample size calculation. You need to figure out what can you claim in terms of statistical significance. And also, if you can do it prospective and potentially external, now you're really getting into the medical evidence realm of these things where people are starting to think seriously about this is the world in which this would be released. So we did this prospectively for 1 year. We basically stopped, it was, let's see, May of 2023. To May of 2024, all of those patients were included as a prospective set, and they were included without exclusion. So we had no exclusion criteria. So anybody who came through the doors at Michigan Medicine, any referral anywhere treated at here or any of our referring hospitals were included as the prospective set. So these were some of the big areas that we took patients from. These were the main counties with these counties really have large-ish health systems that represented a large portion of our data set. So a good sampling from the state of Michigan. And then these are the main results. So the way to read this is called a radar plot. Each spoke is a metric as to how well we do on that classification task. The metric is AUC, so AUROC. So how far out we are on that circle is good. You want it to be a full circle, right? And 52 diagnoses. And 52 is a lot, I can tell you. So what we were trying to do with 52 is pick from all of the major categories that we would see in clinical medicine. In instances of patients coming in with neurologic diseases, what are the most common diagnoses that we would see across a huge swath of different diagnostic categories? Inflammatory, infectious, neoplastic, you name it. We want to make sure we cover all of them, at least to show that this performs well across all of these different tasks. And the point is that we were able to beat 90%. We had about a 91% performance averaged over all of these different tasks, which was fantastic. And then what you may notice on the inside are some of these other circles that don't look as good, that are kind of hovering around 50%. That's what happens if you take off-the-shelf models from OpenAI or Google or Microsoft and evaluate it on this task. And what you see is that 50% is basically random guessing, right? And the reason it's random guessing is because the internet does not contain MRIs. The internet does not have volumetric data. Why? You cannot release them. You can't release somebody's face on the MRI. It's a patient, right? So the availability of this data type is completely inaccessible to all of these Fortune 500 companies, right? They are never going to be able to give you GPT-4 for MRIs. It's not going to work, right? Right. So we were very excited about this. We do think it needs to come from universities. It needs to come from academic departments because I'm telling you, OpenAI is not coming to our rescue. They're really not. They have too many other things that they're working on, and medicine is not going to be one of them. So this is fantastic to see. We see that it scales. This is really important, especially in this day and age. So for any of the students in the room, you get some data, train a model, you get a metric, you see it, okay. You need to then think about what that number means, right? And what's the next move? Because the number, it's nothing. It's nothing. You don't know if it's an upper bound, is it a lower bound? Is it going to get better if you get more data? Is it going to get better if you have a larger model? You have no idea. So thinking about scaling is really important. And we know that there's at least 3 axes of scaling: model size, data size, and compute. We know that for sure. These are the Pareto scaling laws. So the important part about this is that for me, it was about the data. We can always kind of scale up the model. There's some technical issues with that. But what we wanted to show is that if we brought in Ohio State, if we brought in another medical center and doubled our data set, are we likely to get better performance, or have we saturated? Are we at the max as to what we can achieve? And certainly we have not saturated. So I do not think that we are anywhere near where we can achieve, especially given the scaling that you see with increasing the amount of data that you train on. So this is something, again, where we want to claim that, yes, we have a model, here are the metrics, these are not the top. They're going to continue to improve as long as we get more data. So, so that's that.
We know the need down there pretty well.
Right.
Let's stop.
So one of the other things that are really important is how do we affect radiologists? This is in no way meant to be antagonistic to radiologists, meaning that this is a system that I want them to use, I want them to embrace. We work with radiologists. The chair of radiology is part of this research that we're doing. And I was asking him, well, how can this help you? Right now, how can this help you? And his big thing was prioritization. Because when they come to work, they get like 15 scans, and they have no idea what's in it. They have no idea what to make of any of it. One of them could be a horrible tumor or something that's very high priority, but they're basically just getting them chronologically when they were ordered. And his point about it is that we know that errors increase as we go further in the day. So if I'm a radiologist coming in for my 8-hour shift, if I'm reading in the 7th hour, the errors go up. That's been known. So his point about it was, we need to know if it's a hard case, we want to know early in our shift to make sure that we're not making any diagnostic errors. So we were able to show that we're able to rank these in terms of acuity. So basically the ground truth is each one of the individual columns here. And then these are the priority scores, and we have them normalized between 0 and 1, 1 being high priority, 0 being low priority. And again, this is a challenging task overall because the model needs to assess the severity, which can be quite nuanced. And luckily we were able to get this done. And then the other bit is referrals. So that affects me, right? Northern Michigan, patient comes in, has some diagnosis, some brain tumor, whatever it may be. We know if you're in Northern Michigan, you may wait up to 7 days or longer to get that MRI read by a radiologist, right? This is rural medicine now. And they have to outsource a lot of these readings. So someone comes in with a bad left frontal glioma, that patient needs to be seen immediately. They need to be, basically, we will transfer them via ambulance to Michigan because they need to get usually surgery within a week or so. We're talking about sending them home, them sitting at home, probably getting worse, their MRI not being read, finally getting read. Then a clinician needs to figure out this has been read. Then it needs to figure out, I got to refer this to Michigan. So it's got to fill out the paperwork. He's got to send it in, fax it in. Snail mail. It's crazy. So we need a system to be able to say with some high priority, this is a bad problem. You can't wait the normal amount of time to get this read. So we needed an automated referral mechanism to say, this is a brain tumor, this is a bad brain tumor, and have a way to alert individual departments, neurology and neurosurgery departments, that these patients need to be seen sooner rather than later. So we were able to show that we were also able to get excellent performance in terms of automating the referral recommendations. Again, the metrics here are just numbers. These will continue to improve as we get more data. And then we also know that these features generalize. So we trained it on specific reports. We're looking at these reports. We're trying to do radiologic diagnosis, et cetera. But we also want to show that we can use this for certain other known diagnostic tasks, research tasks that are relevant in the literature. And we focus on autism, dementia, and brain age estimation. Those are kind of, I think of as sort of the big three. Autism spectrum is very important because even in children, You may want to assess whether the likelihood of this patient developing autism or somewhere on the autism spectrum in the future. It's a very hard task, but because of the scale that we were training on, we were able to do very good. Why is that true? The autism data sets are about 5,000 patients if you're lucky. So we're talking about scaling by orders of magnitude. We're increasing the amount of data that we have to learn the MRIs, and then we can just fine tune it on a pretty small 5,000 instance data set, right? This is GPT. This is why it works so well, right? For question and answer tasks, for example. Dementia, we did great, and then brain age estimation, again, this is performant with some of the state-of-the-art models. So really excellent to see that this stuff scales well and also generalizes to other tasks. It's trustworthy. That's really important for medical diagnosis. How do you know it's not looking at something spurious, right? Take, for example, autism. What if it's biased towards predicting autism just because it's a younger MRI? It's a younger patient, right? It can look the face. So if it's just saying, look, this kid is young, he's getting an MRI, that's going to make my prior on that is going to be much higher because it's just a young patient. But I'm not even going to look at the brain, right? I'm just going to increase. That's a problem. Same thing for a lot of these other diagnoses is something about the protocol, the way we're acquiring the MRIs or the scanner or whatever it may be influencing our prediction, which shouldn't happen, right? In this case, what we were able to show is that if you look at the area in the MRI that's most diagnostic for any one of the 52 diagnoses, we were able to show that it's honing in right on that thing. So let me just show you here. This was a patient, a low-grade glioma patient who came in, had an initial resection, a subtotal resection. So this is the most important token for diagnosing low-grade glioma. And what we can show is that the residual tumor is clearly within this region, and also the old resection cavity is in here as well. You can see my thing. Yeah, okay. So clearly it's looking at the right spot. It's looking not like in the ear or something, So that's great. And then also when the patient, after 7 years, had all their treatment, unfortunately, these all progressed to being malignant gliomas. Our model, its name is Prima. I don't know if I've told you that yet, but we named her Prima. She was able to basically say that this tumor not only is a glioma, but it's now converted to being a high-grade glioma. And it looked at the regions that were most diagnostic for being a high-grade glioma, in particular regions of new contrast enhancement. So that's fantastic to show. And then fairness. This one's really important. Anybody who's going to do large-scale AI has to do this now. You look at some of the papers that come out, Meta, they spent a lot of work, especially with the SAM paper, talking about global representation. So they talked about how many images came from Africa, how many labelers were in Africa, right? How many different instances of different racial groups are in the image set that we're actually working with. Those things become really important. As you know, there's been some controversial things, especially with the image to text generation. You tell it to generate a doctor, and it generates 4 images of a man. That's a problem, right? So these things become very, very important as you start scaling to large instances. People actually are at stake here. So in this case, what we were able to show is that we have health system bias here at Michigan. If you live in a rural area, you're going to wait longer. You're going to sit there while your MRI, nothing is happening. You don't have a radiologist that has access to you, so you're going to wait longer just because you live in a rural, kind of poor region. Okay, that's number one. Location. So this is, again, depending on where you live, which is obviously correlated with population, but depending on where you live, you may also wait longer depending on the resources within your region, right? This is something that's not altogether obvious because even though you're going to an imaging center, you're getting your MRI, you kind of think that somebody's going to be looking out for you. Somebody's going to be, reading your scan, but it turns out that you may wait longer just because of where you're at. And then also with when you got your MRI, there is a weekend effect. We proved it. If you get your MRI on Friday night, nobody's likely to look at that MRI until Monday morning, right? And that's true across the whole state. So again, this is a situation where AI can really help mitigate some of these biases that we have. Now, it's nobody's fault. We all, live in the real world, but we really have to note that we're not doing our best sometimes for patients, right? Which is ultimately what it's about. It's not about jobs, right? It's about how do we treat patients. So we were able to show that our model is fair across all those groups. So it doesn't matter if you're in Northern Michigan, if you're in Southeast Michigan, doesn't matter if it's on the weekend, doesn't matter if you're in a rural area, it's going to give you the same performance across the board. It's not going to be systematically biased to missing certain diagnoses or being confused or biasing one diagnosis or the other. We were able to show that the disparity in the classification performance is not statistically significant across all the sensitive groups. And we looked at it for race and ethnicity, all of the major sensitive attributes that are common in bias, algorithm bias literature, we were able to show that this was not biased. So, okay. I'm gonna pivot here and talk a little bit about some of the intraoperative imaging work that we're doing, okay? And this is work, I'm so proud of. Chang and Renly have been the core of this research project. Akhil just published a massive paper. I couldn't be more thrilled to see a research program flourish like this has, and it's really grown up. I think we were a little bit ahead. We're publishing all this stuff about computational pathology, optical imaging, and then really last year, the whole field really exploded. It was amazing to see the pace of progress. And this is, I think it's going to be the first instance where we really see AI being integrated into the interpretation. It's amazing. It's amazing. So I'm glad to just be a small part of this. But the reason why brain tumor surgery is hard is this is an instance of an MRI that we may get. It looks like this. So again, luckily, Prima's pretty good at diagnosing these things. But the problem is you get in the OR and it looks like this. So you've done your craniotomy, you've opened the dura, you're looking at the brain. This is what it looks like. The problem is that for those of you who haven't seen a brain, this is basically a normal brain. I couldn't point to you where that tumor is. I don't know. It all looks normal to me. So, but you got to make a move. You're in the OR, you're there, you probably want to do something. So you got to start, right? And you kind of use some image guidance, you use a couple things to try to tell where exactly that tumor is. But ultimately, you're faced with, if I don't remove enough, now I'm leaving tumor in the head. If I remove too much, now I'm removing the patient's normal brain, right? Which feels a little strange, right? I don't feel like I have any brain to spare. So you certainly don't want to be too far on either side of that, right? And I can tell you the major problem with gliomas is that these are infiltrative tumors. It's not like it's a ball. It's not like you can just get around the ball and it delivers itself nice and easy, right? It's actually infiltrating into the parenchyma itself. So you kind of have to play this game of, do I resect more? Do I resect less? And we don't have good mechanisms to be able to sort that out. And we do know that we really don't do well enough. Less than half of patients get their optimal surgery. When we look at the postoperative MRIs, most surgeons will say, we could have done a little bit more here, there's a piece of residual here, but often we don't take those patients back just because of the morbidity going back to surgery, right? So we have some tools, intraoperative MRI, that is our intraoperative MRI here at Michigan, it's over at the Mott Hospital, and then we also have fluorescence. I can tell you this is very stale technology. This is the 5-ALA fluorescence has been FDA approved since 2008, but nothing else has really happened. And this was part of the thing that motivated us to work on this. And the standard way for tissue to be evaluated is very slow. It's like 19th century technology where you take a piece of tissue, you send it to a pathology lab, they stain it. Neuropathologist needs to sit there and read it analog style on a microscope, and then they're going to give you a diagnosis which is pretty hedgy. It's not very good. And the reason for that is because the images aren't very good, right? They're frozen. They have frozen artifacts, sectioning artifact. They just look really bad. This is a whole workflow that needs to be updated. AI needs to be part of this update, right? We're still doing frozen sections, but I'm telling you, it's not the future. So what we've been working on is something called stimulated Raman scattering microscopy. This lives in our OR. So this is actually, we have one at Mott, one at Maine. There's, I think, 25 imaging systems across the globe now. So we do it in lung, we do it in prostate, we do it in brain. That's where it really grew up. We get these very nice looking images that are label free. What I mean by that is you don't have to stain it. So it's, you take it out of the mouse, or you take it out of the head, or you take it out of a patient, whatever it may be, and you don't do anything to it. You put it on a microscope slide and you image it. So there's no H&E stain, again, no fluorescent probe or anything like that. And then you need to do something with it, and that's where we come in with our AI, and then we train it to do certain diagnoses. In this case, we can give it a WHO classification of being a diffuse astrocytoma, for example. Okay, we have tried to fill out all the main problem points in intraoperative imaging and intraoperative pathology. So what are those? We need a histologic diagnosis. That means it's kind of cell of origin. Is it a glioma or is it a metastatic tumor? Is it a meningioma or is it a pituitary adenoma? Is it a lymphoma or is it a glioma? High-grade glioma, for example. All of these distinctions are really important for the surgeon because it completely changes your approach to the operation. That's the first level, right? That's kind of what you get out of frozen section diagnosis, but it can be improved. Tumor recurrence is important because we often have situations where we're not really sure if the patient has recurred, and we're going to bring them back to the OR to potentially do a resection. Sometimes there's very little recurrence, so we need that information at the time of surgery. Skull-based tumors is something I do a lot of. It's a whole nother beast of set of diagnoses, but also really important. Molecular classification is essential now. We're dividing tumors up based on their genomes, as many people know here, right? Most of the time, we're interested in the actual molecular markers for these tumors, and then tumor infiltration detection, which was Akil's big paper. It came out last year, absolutely fantastic. And he developed something called fast glioma, which is this margin problem, right? Don't cut the brain out, don't leave the tumor in, right? You got to find that medium. And what we were able to do is to show that if you resect these tumors and then you image the margin of these patients, you're imaging the resection cavity, you're getting these awesome SRH images that look fantastic in the operating room. And then Akil was able to train a vision transformer in order to be able to output an infiltration score. So given this piece of tissue, there's going to be some normal tissue in there, but there's also potentially going to be some tumor infiltration. We want to know what percentage, more or less, of that tissue is tumor infiltrated, right? It's not, you can get a yes, no out of that. You just need to set your boundary somewhere. But we also want a score that gives us a spectra of the degree of tumor infiltration. So he was able to do this really impressive work. And we were then able to test it in a prospective fashion where we were testing it against the standard of care. This is the intraoperative MRI and the fluorescence that I was showing earlier, right? Those are the two things that we do that the FDA has gotten behind, and we wanted to show whether we could beat that standard of care. So we did this here at Michigan and at UCSF, and we were able to show, so these are the ROC curves on the left-hand side. The curve is nice because that's our fast glioma, because we get a continuous score. We can actually populate a full ROC curve. The points are the performance, sensitivity, and specificity for the standard of care, what we are doing now in clinical medicine. So 5-ALA is the fluorescence. Flare positivity and contrast enhancement are the two markers that we use in low-grade and high-grade gliomas, respectively. And basically, we crushed it, right? It's not magic. The reason we crushed it is because the images are better and the AI is better. That's really all it comes down to. It's not like we had to do anything crazy fancy to do it. We just needed to build it out, make sure we didn't make any mistakes, and prove that it works, and it does. And the important bit is this last figure, which is ultimately comes down to patients. We had 129 patients in the prospective set where we compared MRI, fluorescence, and fast glioma, and we were able to show how did those patients end up? How did they fare? How many patients had a piece of tumor left in their head? And the answer is that if you use fast glioma, if you use this particular strategy, that number completely drops. It drops not quite to zero, but we need to get it to zero, but it drops near zero. And we really see a huge reduction in terms of the overall risk of having dense residual tumor within a patient's head after the surgery. So it was a really excellent outcome. I think the whole field was very excited about this. It was a fresh take on how we treat brain tumor patients and how we really introduce it into the 21st century, integrating AI into some of these clinical decision support tools. So. Great. And this is really part of a sequence of publications. That's the way I understand this. So everyone in lab has been very much involved in each one of these, but there's really, I think, of three phases to this kind of work. There's initial diagnosis and classification. We have done that. This was just a couple of years ago, but we've really shown that we can do histologic classification. We can do molecular diagnosis. Akil wonderfully populated the idea about how do we do margin detection. Chang and Renly have been absolutely impressive in terms of their technical ability to improve the way we train these models, which is not a given, right? Visual representation learning is still a very active field. If anybody of the students here are interested, it is not solved. Vision transformers are not the solution. If anybody is wondering that, we've just pushed images into transformers and call them vision transformers. There's a lot of work to be done here. So if anybody's interested, it's really important. And then the next phase of this that I'm excited about is again with Renly, and this is something called survive glioma. And once we've diagnosed, treated, we now need to predict how well this patient is likely to do, because that dictates all of their subsequent treatment predictions. And that's what we've been working on. And Renly has been doing a fantastic job where we have some stratification of these patients based on some of the molecular features, but ultimately we're stuck as a field. The reason we're stuck is because we have sequenced the genome. We have a complete understanding of the genome of diffuse gliomas. Those are the most malignant brain tumors. More sequencing is not going to get us anywhere. We already know the somatic landscape of gliomas. The problem is that we still see a huge amount of variability in the survival of these patients within specific molecular subgroups. So we need a better mechanism to stratify that survival. And Renly has already shown that we have some ability to be able to stratify the group with the largest variance, that's the astrocytomas. So he's been able to show using some computer vision strategies over both SRH and H&E images that we're able to get good survival stratification using computer vision. That's one part of a larger system that we hope to build out over the next really year and a half, which is integrating as much patient information as we can, including the H&E, including the pathology, but also including the MRIs, including the clinical features, and some time series analysis to be able to predict how likely this patient is to survive to 5 years, for example. That's all part of this multimodal learning that I think is so critical. There's a huge amount of literature predicting how long a patient will survive from an H&E image, and that's fine. We certainly need to do that, but that is going to be a very incomplete view of that patient, right? You're talking about reducing an entire person down into an H&E block. That's it. That's all you get to predict their survival. That doesn't make any sense at all. Imagine being reduced to a little piece of tissue and a little H&E stain. It doesn't make any sense. So we're trying to build out a system that actually represents the whole patient. And then Chang. This is Chang's work here. So Chang and Renly have been absolutely dedicating their lives over the last several months, generating the most comprehensive pathology data set I have ever seen. There is a lot of large-scale pathology, computational pathology data sets out there, but unfortunately, they're 10,000 miles wide and like an inch deep. So you can download all of TCGA. There's lots of H&E images for breast, kidney, lung, prostate, brain. It's all in there, right? And that's fantastic, but it's a very limited representation of what pathologists do to assess patients and assess the tissue that they've been given. And there's a whole battery of tests that this tissue undergoes in order to be able to render a diagnosis. So what we're trying to do is, rather than being 1,000 miles wide, we want to be at least a couple miles deep, right? We actually want to be able to have a data set that is representative of how we diagnose these patients in real laboratory medicine. So they have been imaging the entire evaluation of, now we're up to 2,000 patients. What do we got? Not quite. We have 20,000 slides, but we're getting up to a huge number of patients. But the point is that we're really excited about this. Hopefully over the next year, we're really going to be bringing in a lot of the foundation modeling that has come from computational pathology, combined with this big data set that we think truly is comprehensive for neuropathology, to be able to really simulate the diagnostic workflow that we see in the neuropathology labs. So again, this is all thanks to DCMB, because if I didn't have Chang and Renly, none of this would happen. So, so this is the lab here. I couldn't be prouder of this group, just doing fantastic work. Again, I'm taking credit for all of their hard work, which I'm happy to do. So, anyways, it's really an honor to be here. And then I also just wanted to, I think Dr. Omenn is here. So I just wanted to say, I remember where I was standing when I got the email about this gift. I was at a neurosurgical meeting. It was in Half Moon Bay in California. I got the email. I was just about to go to the conference, and I got this email, and I was so blown away about this, because I think this was really a recognition. I don't want to speak for Dr. Omenn. He can speak for himself, but I think this is really a recognition of how important this is going to be, right? This is something that really is going to be part of our lives. It is something that we need to embrace. And I think that we can be leaders here at Michigan. We really can be the people who are at the cutting edge and making sure that AI is used appropriately, it's used fairly, that the performance is high enough to really be part of the clinical workflow to improve, clinicians, to improve diagnoses, to really help the way we treat patients. And I just love this news clipping that I saw also. So anyways, I'm not surprised. I think that's a pretty good characterization of Dr. Omenn. So anyways, thank you very much.
I've actually been watching, Todd, and as you did a beautiful job not too long ago, leading off our kickoff for the academic year back. We're so proud of how you're doing and how you're building your program and bringing young people into your lab to great starts on their careers. It's all wonderful, and you're going to help a lot of patients with this approach.
Thank you, Dr. Omenn. Great. I think we have a little bit of time for questions.
You know, this is kind of will come off as a dumb question in some ways, but I wonder if after you do the margin determination through your surgery, whether you can put the fluorescence in there to see if any residual is there.
Right.
To
Yes.
clean it up. You know what I'm saying?
It's a great point. The wonderful thing about this, and this is something we try to emphasize in the paper, is that none of the strategies are antagonistic. They're all synergistic. So
Exactly.
you can use all of them in the same patient. And there are some limitations. So for example, for the fast glioma is that you get extremely dense information, but at a very small spatial resolution. So you're really only sampling a couple of millimeters of this resection cavity. You're not getting a lot of surface area information, where with fluorescence, you really get a wide field of view.
Exactly. Yeah, that's
So what we've kind of gotten feedback from is that there will be an area, there's some areas of the resection cavity that you're pretty confident is not likely to have any residual tumor. But you may see an area that does have some fluorescence. That's the area where you can often target with fast glioma to see, is it aberrant fluorescence? Is it a false negative, for example? And it gives you much more granular information about that tumor infiltration. So
another question relates to, you talked about all these different lymphoma versus glioma versus this versus that. I was just wondering, somebody who's not an expert, when you start the surgery, how much uncertainty is there on what they have versus what you end up having to discover along the way?
Right. Yeah. I mean, I'm embarrassed to say that often there is less than what we would like to admit. So I'll give you a great example. Lymphoma is the scary one because lymphoma can look like anything. It usually looks like a high-grade glioma. Now, high-grade gliomas, we know, should be treated with safe maximal resection of the tumor. The kicker is, again, lymphoma can look exactly like high-grade glioma, but lymphoma is not a surgical disease. We should not be operating on that. So if you get that wrong, not only have you removed a large portion of this patient's brain, it wasn't indicated to start out with.
Yeah, exactly.
So that is and it's always on the horizon. It's always out there. There's landmines out there. So if you swing and miss and that patient does worse, is a very vivid memory I have when I was in residency. Excellent brain tumor surgeon that I was working with that was on faculty, did this resection, did a really good job, but unfortunately caught a perforator that caused a stroke that left the patient hemiplegic. That can happen. If it's a low-grade glioma or a high-grade glioma, you can kind of accept that as sort of part of, the risk of doing business sort of thing. But it was a lymphoma. We missed the diagnosis intra-op. We did a surgery that was unindicated and we gave them a paralysis.
Yeah, it's
triple
loser.
It's just the worst, right? There's no excuse for that. And when I hear these errors, again, this is where I just feel like we're really confronted with our own limitations, and we should have known before we went into the OR. We should have something that would tell us, say, for example, the MRI system that we have. We need probability distributions over these tumor diagnoses. So given all of the images that have ever been done in the history of time and the associated pathology for those patients, I want a probability distribution over all of the most common diagnoses that we would expect. And what would be extremely helpful is know with 85, 90+%, preoperative probability, that's going to be a lymphoma. Because that puts me on alert. It puts the surgeons on alert. So they know that before they even start, it's likely to be a non-operative lesion. Do a small surgery, get a biopsy, and send it to the pathologist during surgery, or we can image it with our system. If it comes up lymphoma, great, you're done. There's nothing left to be done. If it doesn't come up lymphoma, then maybe you need to do a little bit of work. Maybe you need to do some more sampling. Maybe you need to send some more tissue, whatever it may be. But to go in blind, it's absurd. We got to get past it.
What's really interesting, I just thought of this as you were talking, that once you have the outcomes, then you can go back and retrain the system.
Yeah, exactly.
Based on what you found.
Right.
And correct some of the errors of classification.
Yeah.
and find some of the hints that would allow you to make a better differential diagnosis in the first place.
It's a deep point that you just made. So this is something we're working on in lab that I feel like is so critical. So radiologists, you think about these learning feedback loops. So this is basically backprop on humans, right? Okay. So what do you have? What do we have as a learning? You need some sort of feedback loop. With radiologists, they are trained to read these images, and they're trained to be able to learn all these features and associations between this kind of contrast enhancement and this kind of appearance on these different sequences, and how likely it is to be this specific diagnosis based on textbook, based on their training, based on those sorts of things. The problem is that they are not reading the pathology reports. They are not following up on that patient that they come into the emergency department, they read the MRI, they get their 15 images for that day.
This is
they
the
read
assembly
them,
line issue.
and now they're like, here you go, surgeon, do your thing. So then we do this thing, and then we get the pathology report usually 2 weeks or so after the surgery. I can tell you, radiologists do not have the bandwidth to read the radiology reports for the patient that they had read 14 days ago, because they have another 15 patients that day, right? So we're not backpropping on the pathology reports. It's crazy. It's just, we're being confronted with the limitations of our own humanity. When we hear these things, there's only so much we can do, and people are suffering because of it, right? And now that we know that we kind of have a competing digital intelligence that may be able to help us with that, it really changes our view of the errors that we have been making and whether they're really acceptable, because I'm not sure they are.
Not, I would say not competing, but collaborative.
Exactly.
Let me give this over to Aaron so he can find some student questions up there. Nice job.
Please.
Thank you for your last talk. Actually, I have two questions.
Uh-huh.
So when developing the digital pathology model, there is a kind of issue of resolution.
Yes.
All images are having different resolution,
Mhm.
MPP values. So I'm just curious, what is your strategy? Resolution agnostic models were depending on a certain resolution.
Mhm.
And the other question is, are you trying to get your model FDA approved in the end?
At the what? Say-
FDA approval.
FDA approved, gotcha. Okay, so by resolution, you kind of mean like magnification, for example? So yes, so right, for whole slide images, we do scan at multiple resolutions or magnifications. Yes, there have been people who have worked at having a hierarchical model with the hierarchy defined over the resolution. I think that's certainly a good strategy. I can tell you that having seen a lot of neuropathologists read these scans, they often start at like 5x or 10x maybe. They're basically looking for the overall sort of gestalt picture of the tissue. It can really help just looking at the coarse sort of low frequency gradients between blue and red, because that gives you the level of cellularity. It'll tell you over the whole tissue how cellular is it. And then often what they'll do is they'll go down to a higher magnification to be able to see a lot of the high resolution features. I think there's no reason why we can't implement a similar type system to be able to do that. Sort of the standard way to do everything is usually 20x. That's sort of the norm, but there is some evidence that doing things at 40x may be better, so I think it's an open question. If you're interested in researching it, I think it has not been solved. And again, vision transformers are not the answer, right? It's not, you just can't throw a vision transformer at everything. It's just going to work, right? So that's a great question. FDA approval, yes. So the imager that we have right now is FDA approved. So we're using that across the board. We have a breakthrough device designation for an AI on that system, but it's actually for lung. I'm sort of peripherally involved in the company, but we did start in lung just because it's so much more common. And the diagnostic task is really just normal lung versus tumor. With granular diagnosis, it's harder to get that through the FDA, but I can tell you it's going to happen. I mean, they're starting to do better and better job approving AI devices, AI models for medical applications. So it'll happen for sure.
Sure, we should sit down and talk about it, because there's all kinds of things that we could do to justify the move to 40x.
Right.
It's a simple thing to prove.
Mm-hmm. Yep.
So
I might just comment that the FDA has now approved over 1,000
Yes.
devices, they call them devices, algorithms for clinical applications. Some are by clearance, some are by a direct approval, and none of them really have had any post-marketing surveillance and assessment of their usefulness.
Mhm.
80% of them are for radiology.
And these are AI applications.
Yeah, right.
Yeah.
Haven and I have been dealing with people at the FDA the last several months.
Hi, I'm Joshua Pickard. Thank you for your talk. I really enjoyed it. It was really interesting.
Thanks for coming.
On the note of how these are being deployed and how they're getting approved, one thing I'm curious about is when they are being deployed, are they sort of locked in the sense of all of the training is done, you've trained your model, now you're only deploying the model? Or once it is being deployed, I'm curious how much control you have to be able to take the new data that it is actually making an assessment on and using the outcomes of that to go back and update your model.
It's a good question. Dr. Omenn may be able to speak to this better than I have. I have not yet been involved in a situation where, let's say you do get something approved and then in 2 years you're coming out with like 2.0 version. It seems to me like you would have to have some sort of regulatory overhead for that, but it should be less, right? Because I feel like the big thing is with the FDA, that's really about safety, right? We need to make sure that if we put this out in patients' hands, you're not going to hurt somebody. And in general, if you're updating the model, it's often about performance, right? You're trying to boost the performance of that thing, but the safety profile shouldn't change too much. So
This is Gail knows, Dr. Omenn knows about this. This has been a problem for a long time
Yeah.
because there are incremental improvements.
Right.
But you're not actually allowed to implement those improvements from
Right.
a regulatory perspective.
oh, I see.
So there has to be a timeline, a process kind of negotiated with the Food and Drug Administration
Right.
for that purpose. And, it's not like, we're at version 1.05 or something
Yeah,
like that.
right.
So that's got to be built into your the discussions with the FDA at the time of approval.
Makes sense.
Yeah, it's an important point. And Gil, I know you're probably running into this.
Actually, Brian, the FDA staff say that they have no authorization from Congress to do post-marketing studies or require them. So that's something that should be fixed when we have a rational FDA.
Yeah, that's
Progress.
a broader, putting aside
I like that.
the immediate problem. I mean, that's actually a broader and more powerful statement
Right.
than what I was making, which I've had specific instances of that where it's really a problem.
Right.
In the whole post-market. See, so I was thinking about not post-market per se, that like a device that's released out into the wild or something like that.
Yeah.
I'm thinking about, something that's implemented in a system where you have ongoing clinical studies and improvements,
Right.
setting milestones and markers for improvement.
Mhm.
It's still, it's still a problem to implement those incremental changes,
Yeah.
appropriately. Okay, any other questions? Well, listen, one more, Matthew.
Hi. Hi, I'm Allie, and thank you so much for your talk. I'm an undergrad student, and I'm like relatively new to like this application of AI. And I was just wondering, when you talked about bias, how did you account for like not having or having as little bias as possible in your training and your data sets?
Right.
Because it's hard to do sometimes.
It's really hard, and that's why you do need to test for it, right? Because the simplest explanation is you just don't have a good representation of a specific group of people or a specific attribute. So if you take race, for example, there's going to be differential a race distribution across the state of Michigan just because of the population, right? If you're going to train a model like this, there's obviously going to be big differences in the representation of that group, those groups of people during training, right? Now, the reason you want to test it moving forward is that you want to see that because you have an underrepresented group, you don't then subsequently have, when you look at the performance in that group in a prospective set, that you're underperforming, right? You want to see that that difference in the training set does not propagate to whatever testing set that you're interested in. And it can happen. It can happen. Now, hopefully, our ability to diagnose brain tumors across the races is not dependent in any way on their facial features, for example, or their hair type, which you can see on the MRI. that's where it really is an empirical question to see whether that bias has crept into your inference. And, this is where there was, some really bad instances of the image to text kind of things where, you just train it on internet scale, but then you start noticing that, this model is completely biased against this racial group because there's just not that many representative instances on the internet, right? So addressing those things is very serious. And now when you write these papers, which is great, they have checklists for these sorts of things. So if you want to submit it to Nature, for example, they say, we want to know all of the things that you did to mitigate that exact bias that you're talking about, because, it's something that you as a professional, you need to account for. If you're going to be a machine learning scientist, you got to make sure that you are aware of those things. So it's a good question.
Thank you.
Guys,